All right, guys. Hey, what's up? It's Rick Bigger here. Ethan Pack. Pack's gonna help us out. We've had some people have called me and talked to me recently about BIPAP, and we had some issues with some alarms we were getting on there. So Pack's gonna walk through. He has a really good way of setting it up, probably the best that I've seen. So I'm gonna have him walk you through that, and then once we get down to the second part of this, will be kind of the natural progression of treatment if the BIPAP CPAP doesn't work, and how we can kind of go from there, and things that some guys asked me, stuff I had showed them in the field to share with everybody. So I'm gonna turn it over to Pat.
Okay, so how I like to start is make sure I actually hook up the vent circuit correctly. We all know what the big tube is and where it goes, right there. What I've screwed up is the exhalation tube and the transducer. I've screwed that up a couple times. Some of the older vents may not be colored, but they do have helpful little pictures. What I like to start with is I grab the exhalation tube and I just go and put it on. And grab, there it is. O2 tube. All right, and then mask. Try to get a good seal on your patient. Make sure you have your capnography on so you can get all your readings. And then when I go from there, I go ahead and turn it on. I work from the bottom up. So mask CPAP. Then I change it to bi-level for BiPAP. Then I adjust the IPAP to 10. I don't have any oxygen hooked up currently, but I start out at 60, especially if their O2 sats are crap and they're down there in the 60s or 70s. Start at 60. And as they start improving, I'll titrate down a little bit, but I don't typically go below 40. Then I just start watching for, you're gonna get a leak alarm sometimes from your capnography. This setup right here has the leak compensator on, so you will see it whenever it is giving a breath that it's going into over 1,000. They're getting the adequate amount of air they need, but it's just compensating for the leak. Occasionally you'll see where it doesn't have a leak and it's like 300.
Cool. Anything else?
That's where I go.
That's it.
That's my go-to. It's super simple, super easy. I don't need it to be.
All right, guys. So Pat just went over how to set it up. Pretty straightforward. It's pretty simple setup on the BiPAP. The biggest complaint / issue that we get is alarming the vent alarming for patient disconnect, or it's detecting that you have a leak. Okay, so I had one the other day, and they said, well, we have a patient disconnect alarm, but I've checked all my connections, they are correct, and the mask is on, so we don't have a patient disconnect. But you're wrong, you still do, okay? So what that's telling you is that it's detecting a leak. It doesn't know, all it knows is it's not getting the resistance that it thinks it should, according to its calibration, through the ventilator. So that's exactly how you troubleshoot it. I have that disconnect, I start, just like Pac said, at the vent and start looking. Is this on, obviously? Is my transducer on? And my exhalation port, are they on the correct fittings? If they are, then you work your way up the vent and we make sure. So this one here, and you're probably not going to be doing this, but this training tube has a breathing treatment in it, okay? So you'll notice that I taped it before and I put this in there. So this could be the place that there's a leak, or possibly this hose came off and there's a leak, okay? So anywhere along this that you have, just look along your settings. These right here will come off, be popped out just like that. Running that way, you'll have a leak. So just work your way down this all the way to the mask and make sure that you have a good seal on your mask. The next is the mask itself. So pretty much every vent works the exact same way. We are going to do some demos and look at some, and look and see if maybe we can find one that's easier, has a better display, and easier to set up. But a ventilator is a ventilator, so the brands would basically work, very similar. It's more just about preference. What we have done since the 5 years I've been here is we have updated our masks. We used to have really bad foam masks. We have these nicer gel masks now that work a little better. But usually where the leak is the mask itself, because of the patient's face. So like I have high cheekbones, right? Cody has fat cheeks, okay? So this mask is gonna fit differently, okay, in my face versus Cody's face. So you can't just strap this mask on, throw it on their head, and then you're all good. You're probably gonna have to, I'm actually not gonna demonstrate this on you because I don't know how dirty it is. I don't know where this has been. So, you can't always just throw the mask on the person, strap it on, and we're good to go. We want this to be, that simple. I just put my thing on the back of the person's head and I hook it on, and it's universal, right? Everything fits everybody. It's all great. That's never going to happen. Okay, so that's just a limitation of the CPAP mask. So you notice here, all those are leaks. And all those, as Pat was talking about, it's going to throw your tidal volume up and it's going to detect a patient disconnect. Okay? So what you may have to do, once I get to here, is take the strap off the back of the mask. Okay? The first thing that we need to do is get the seal to the face as best we can. Okay? You're going to have to hold the patient's head, right? Get that seal on there the best I can. The next is I have to get them used to it. If you're getting a apnea alarm, okay, we have this one too. The next difference between CPAP and BIPAP, right? CPAP, continuous air, same amount of pressure, whether you're breathing in or breathing out, and it blows all the time, right? BIPAP, right, does not give you pressure on both ways, and it needs to be triggered, okay? So what you'll commonly see when you're in an apnea alarm is the patient is not breathing deep enough in order to trigger that, okay? So you'll put this on their face, and then they'll pull away and try to breathe because it's uncomfortable, and they pull off of it and they try to breathe. And the machine cannot detect that, okay? So you're gonna get an apnea alarm. So I'm gonna have to put this on the patient's face, and I'm gonna have to coach them and tell them to take a deep breath, and get the machine working, get your seal good, and then put this on the back of their head, start connecting it, make it a little tighter, as the patient gets more comfortable, okay? That's never gonna go away, no matter what mask you get, no matter what ventilator you get. You have to learn how to get the mask sealed properly. And a lot of times is getting the patient to calm down because they're also having an anxiety attack because they can't breathe, okay? So those are things with the seal. The next thing is, all right guys, so once we just talked about fixing the seal and getting our CPAP or our BiPAP to work better. The next kind of natural progression of that is if that is not working, is not getting improvement, we have to move on to a separate treatment. We have to realize that one of the indications for BiPAP is the patient's ability to handle the BiPAP, okay? Or if you want to say one of the contraindications is the patient's inability to handle it. Okay? So then we have to move on to the next step, which is either using a BVM to do assisted ventilations or to intubate them. Okay? But if I don't want to intubate them, or they're not to that point yet, then I can assist their ventilations. But two ways that make it a lot easier to assist ventilations or make this work better. The same thing, we're gonna have to put this on the patient's face, right? The old way, we're gonna call it the old way, would be that I'm gonna put this on their face, right? And then I'm gonna start to breathe a little bit until I feel resistance. When I feel resistance, that means they're breathing out. So I let them breathe out. And then when I get to the end of that breath, I assist their ventilation, right? I hold a little pressure on there. I feel the resistance in my hand, and I let the air back out, and I assist their ventilation, okay? There's a lot of people that like to do it that way. That's the way I was originally taught. There's some people that like that way. I have found that doesn't always work well if the patient's not breathing hard enough for me to feel the resistance on the back. I've always struggled with this. Some of it I think adrenaline too. When you're dealing with a stressful call, I don't feel like it. I have trouble feeling that. So a way that I was taught by one of my old medical directors that works really well is to watch the mask. So I'm gonna scoot up, Cody, come here. See if you guys can see this. I'm not sure that you can, but when a patient breathes out, it will fog the inside of the mask, okay? So I'm gonna put this on Cody's face and he'll take a breath out. You see the mask fog. I know that he's breathing out. Now I assist him in and it clears the mask. I let off, I see him breathe out. And I can assist Cody's ventilations perfectly because I'm using the mask. So I'm just watching for fog. I breathe in, that automatically clears the mask for me. When I let off automatically, I wait for it to refog, and then I can assist his ventilations back and forth. So if you're having if you have a problem with how much I assist, or how do I know if I'm assisting the right way, because I don't want to just continually breathe in their mouth, that doesn't help them either. Okay, the fogging the mask is what I found works the best. Okay, so if you have a CPAP problem, you're having an alarm, whether it's a technical issue with something wrong with the vent or something you can't figure out how to work it, we got to move to the next step. Okay, so there should be the ventilator is a non-crucial piece of equipment in the ambulance. Okay, it's there, it does work great, we want to use as much as we can, but if it doesn't work or it fails, the BVM is the manual ventilator. Okay, so we have to be good at the basics of knowing how to assist ventilations. If that doesn't work, then the next step is you're gonna have to intubate the patient. Okay, so you hear people, oh, I don't want to intubate the patient because I don't think they're going to come off the vent, or I don't think they'll come off the tube if I intubate them. They're going to die in the ambulance if you don't. Okay, so that's just that's something that we'll deal with. The ICU and the hospital deal with long term. Your job at that time is to get their pulse ox back up, BiPAP, BVM, and then intubation if we have to. So hopefully this helps you guys out. If you have any questions about this, anything else I can help you with, get with me, and we'll get it out there. Thank you.